Hello everybody, hello everyone, and welcome back again to my channel. For today's video, we're going to tackle about the neurological concepts and disorder, the review of the different diseases. So we have part 1, part 2, and part 3. So we start first with part 1, okay? Without further ado, we're going to discuss first the increase in ICP or the increased intracranial pressure. Now, the normal ICP is 10 to 20 millimeter mercury. Anything that is more than that will increase the ICP or the intracranial pressure. Now, remember this hypothesis, the Kelly-Monroe hypothesis, says anything that would increase in the component of the brain, such as your brain tissue, CSF, and the blood would lead to increased ICP. Okay, remember that the skull is a closed vault and it houses the brain. So anything that would increase tissue for inflammation or blood supply or CSF would lead to increase ICP, okay? Now, these are the predisposing factors that lead to your ICP. So, LITCH, which is L, localized abscess, the increasing brain tissue. Inflammatory conditions such as meningitis will lead to increased brain tissue as well because of the inflammation. The tumor also would lead to increased ICP because of the abnormal tissue growth. Cerebral edema, of course, inflammatory reactions, so fluid retention, that will lead to increased ICP as well. And of course, head injury, which includes your hemorrhages. If you have a stroke or blood clot form on your brain, that also will lead to that. And hydrocephalus, which is increase in the CSF. So that would also lead to increased ICP as well, okay? So we have to monitor this very important topic. Now, as I have told you, the pathophysiology for the increased ICP is the Monroe-Kelly or Kelly-Monroe hypothesis that any increase in one component of the brain will lead to increased ICP, okay? Or any alteration or increase in this structure will increase your intracranial pressure, okay? Moving on. Now, for normal compensatory mechanism for your ICP, this would happen, okay, without any injury, okay? Now, if there is increased CSF production, which is normal is 125 to 150 ml per day, so if there is overproduction of that or normal way, they will be reabsorbed by the brain and utilized by the brain, okay? Now, if there is a blood supply going on, increased blood supply, it would shunt to different areas and utilized by the brain as well. And if there is too much production of the CSF, therefore, the ventricles will lead to decreasing production of your CSF. That's a normal. Okay, now, however, if there is an injury or something going on the brain that is not associated with normal functions, this would happen. The decompensatory mechanism would have decreased cerebral perfusion. So if there is increasing ICP, probably you would have decreased cerebral perfusion. So because the pressure is going to build up, so the brain cannot perfuse normally, like normal function. So like exchange of oxygen and the carbon dioxide is also affected, okay? Now, if there is increased ICP, the production or the utilization of oxygen is also affected, thereby increasing your CO2 production or utilization rather than using the PO2. So that would happen to your brain. The client will also have too much production or injury to the brain would have cerebral edema as well. And as long as the pressure is built up on your brain tissue, because the skull is a closed vault, so it cannot move anyway, then the pressure is built up, it will herniate. So that's called herniation. Now, these are some of the responses when increasing ICP happens. So, like Cushing's response, the Cushing response is called the hyper-Brady-Brady, or the hypertension, bradycardia, and bradypnea. This would happen as the vasomotor center triggers the rise in the blood pressure. The vasomotor center is your medulla oblongata and then your pons, okay? Then the sympathetic responses is stimulated, and therefore it would increase the blood pressure. Now, the sympathetic responses is that they were stimulated, increasing the blood pressure, but it will slow down the heart rate because the brain is compressed, therefore less stimulation of your heart rate center and the respiratory center as well. Okay, so that's why there would be hypertension, increased BP, bradycardia, and bradypnea. So that is a Cushing's response. Next, it's opposite with the shock. Okay, if we're going to compare the vital signs of intracranial pressure to shock, this one is hypotachytachy. Remember, the hypotension, tachypnea, and tachycardia will happen to shock. That's a norm responses when you have that. But opposite to that, with the increasing intracranial pressure, is hyper-Brady-Brady, hypertension, bradycardia, and bradypnea. Don't forget that. However, the clinical manifestation or the first symptoms that we will observe with the client with the increased intracranial pressure is a changes in the level of consciousness. Remember this, guys, okay? Always and forever. Okay, now in the form of what? So the client would have restlessness, confusion, irritability, agitation, lethargy, stuporous, until the clients get comatose. So eventually, for instance, the client had a head injury or car accident. So in the beginning, the client stand up and able to go to the hospital. And then suddenly, after like a couple of hours, they change the level of consciousness, like becoming stuporous and then coma. So it means that there is increasing level of intracranial pressure to the client, and eventually after the 24 hours and the client died. So therefore, too much intracranial pressure. Okay, other clinical manifestations aside from changes level of the consciousness are the following. The client would have headache as well, and that would also cause you to have the projectile vomiting, like you were pump of vomitus, okay? Papil edema, or the edema of the optic disc, like bulging you will see on the eyes. Decorticate posturing is like flexion of the upper extremities posture, that's decorticate. And this cerebrate posturing is extension posturing. When you ask by this, the most dangerous is the decerebrate posturing as compared with decorticate, okay? Decerebrate posturing. Okay, other symptoms includes unilateral dilation of the pupil or bilateral dilation of the pupil. This is called anisocoria, and the other one is isocoria. Okay, isocoria. The client also had a possible seizure, of course, because of the increasing pressures buildup. So seizure might occur because of the abnormal impulsive activity of your brain. It cannot be controlled by brain anymore because of what is going on the brain, okay? Now, we focus on the nursing intervention because they always ask questions related to this matter. So, nursing NCLEX is for nurses, so therefore we have to know the disease itself, the cause, and the symptoms, and as well as importantly, the nursing interventions. Of course, all the time we have to maintain a patent airway for the client. If the airway are blocked by secretions, we have to maintain with that to prevent hypoxia and hypercarbia. Decreasing oxygenation is very risky for the client, and the brain will die, okay? And hypercarbia is increasing CO2. So therefore, carbon dioxide is a toxic substance to the brain and therefore have to be eliminated, okay? Adequate ventilation through maintaining a patent airways. I have told you, they will put test tube. They will put the crate tube if need to be needed. Okay, monitor vital signs of the client. Of course, remember the hyper Brady. Intake and output is very important because the brain has inflammation or edema, so have to monitor the INO. Neurological status of the client, check if they are alert and then suddenly changes in the behavior. Okay, and the Glasgow Coma Scale, the GCS, it has 15 scoring. 13 to 15 is the normal, okay? If you have like 10 to 13, or I guess like 8 to 13 are moderate, and then the severe one are lower score. Elevate the head of the bed 30 to 45, okay, like a semi-Fowler's position, and neutral position of the head. So no to the side, and going down, because it might increase the ICP as well. Okay, limit in fluid intake. Okay, it means limit. It not mean like avoid. We still need water, but 1,000 to 1,500 ml per day is very important for the client. Still need with that. Prevent complications of immobility, turning the client every 2 hours, or you can do the range of motion exercise for the client. Prevent increased ICP, avoid the following activities, okay? Remember, this is also commonly asked. Avoid Valsalva maneuver because they will create more pressure. Avoid constipation because you would have Valsalva maneuver as well, increasing ICP. Avoid excessive coughing. That's why when you do the client have a trach, then suction is necessary, but excessive coughing is not, okay? Excessive vomiting, of course, because it might increase ICP. Lifting heavy object, if the client was able to go already on the restroom, then don't lift heavy objects. That would also could cause Valsalva maneuver. Avoid bending and stooping. Of course, it might increase ICP. And do not cluster nursing activities. Of course, the client might be stressed, and that will lead to increased ICP as well. Remember those. These are things that we need to understand when it comes to increasing ICP. Other nursing intervention included our ordering of the medications by the doctor, and we have to administer prescribed medications, including your osmotic diuretics. This would help to decrease or eliminate the cerebral edema or swelling. Now, example of this are mannitol and osmitrol are given, and nursing consideration when you were giving this medication, because it might cause you to decrease the blood pressure, or hypotension is most common because you are eliminating fluid and sodium, therefore decreasing the blood pressure. Monitor. The second one is monitor the INO of the client every hour and report if there is decreased fluid production less than 30 cc, because the client needs to eliminate the fluid, and therefore if there's decrease, what happens to the fluid? So there's fluid retention, so you have to check on that. Mannitol osmitrol is administered via side drip. Check on that, my friend. And then regulated fast drip. That's why eventually the client would have elimination of the fluid easily. Okay. Also give loop diuretics. What are example loop diuretics? Are Lasix or your furosemide. These are given IV push, and eventually fast reaction, and the client would urinate 10 to 15 minutes. So that's why we have to monitor the client for hypokalemia, hypocalcemia, and hyponatremia. These are the normal values for this, okay? Okay, other nursing intervention for increasing ICP is also giving corticosteroids because the client had the cerebral edema, so the dexamethasone is given too. Mild analgesics given for headache, such as codeine sulfate. So remember, headache promote vomiting, so we have to lessen that, or promote appropriate dim of light, so to avoid headache. And anticonvulsants are also given to the client to prevent seizure. Okay, that'll be all for increasing ICP. I hope you learned from that. If you do have questions or any clarifications, please comment down below. I hope you learned from that. Thank you and God bless.